But in American everyone. I am Dr. Sanket Niwale, representing Medical Affairs at MK Pharmaceuticals, and we are yet again meeting for another exciting episodes in neurology cases pertaining to stroke called as the No Thrombosis Workshop Series in Acute Ischemic Stroke. I take this honor and privilege to introduce our course director today, Dr. Subhash Kaul sir. Sir is a senior consultant and stroke specialist, KIMS Foundation and Research Center at Secunderabad. Faculty for 27 years at Nizam's Institute of Medical Sciences, Hyderabad. Former professor and head Department of Neurology and Dean at NIMS. 120 publications in national and international journals. Principal and co-investigator of several national, international projects, including largest single center, Hyderabad Stroke Registry, funded by the ICMR. State Teacher Award by Telangana Government, 2017, has been the past president, AP Neuroscientist Association, past president of the Indian Stroke Association, and the past president of Indian Academy of Neurology. Sir, you had been there from the first day of this workshop series as our course director, and we are happy to welcome you again, sir.
Thank you.
We have a moderator today, Dr. S. Meenakshi Sundaram, sir. Sir is a senior consultant neurologist, Apollo Hospitals, Madurai. Over 20 years of experience in neurology, presented many papers at various prestigious national and international forums, received Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology, Lucknow, 2002. Principal investigator for many international trials such as the refractory partial epilepsy, stroke, acute stroke intervention trial, and PD trial. Editor of the South Asian edition of the book Practical Neurology. Also contributed to many books on neurology. Sir, we welcome you for the event. We have Dr. Rahul Kulkarni, sir. Sir is a senior consultant neurologist at Mastiksha Clinic and Dinanath Mangeshkar Hospital, Pune. He has been involved in clinical trials since 2006, publications in national and international journals. He has presented papers and posters in many national conferences. He is invited as a speaker in various national conferences, recipient of numerous honors and awards. He is actively involved in public awareness programs to spread knowledge about neurological disorders. He is frequently heard on radio or seen on TV speaking about neurological conditions. Sir, we welcome you for the event.
Thank you.
We have our first expert speaker, Dr. Sadanand De, sir. Sir is a senior consultant neurologist and stroke specialist, Apollo Multispeciality Hospital, Kolkata. Multiple national and international publications, presented paper in national and international conferences, actively participated in multi-center randomized trials during the fellowship. Recipient of the Young Neurologist Award from WSO in 2014. Actively involved in acute stroke management, both intravenous thrombolysis and endovascular thrombectomy. Actively involved in raising awareness of acute stroke management at the state level. Sir, we welcome you for the event. Our second speaker today would be Dr. Praveen Kumar Yada, sir. Sir is a consultant neurologist at KIMS Hospital, Secunderabad. He is a member of the Indian Academy of Neurology, Indian Stroke Association. He has done case presentations at various forums, including API 2006, Guntur, Koni, Bangalore 2012. Co-author chapter in Tropical Neurology. Multiple presentations at various platforms, also presented poster at Econ 2000 in Hyderabad. Sir, we welcome you for the event. And now let me hand over the podium to our course director, Dr. Subhash Kaul, sir, for his opening remarks. Over to you, sir.
Thank you, Sanket. I think, as always, it's a pleasure to attend this very informative program in which we get insights into the individual cases. As we know that guidelines don't always help us, because guidelines depend on clinical trials, and clinical trials depend on aggregate of data of hundreds and thousands of patients. But unfortunately, patients, when they present to us, they don't present as aggregate. They still come individually. So therefore, individual case presentation is extremely important, which many times gets diluted, obscured in the clinical trial data. That's why if you see the recommendations in data also, they are never sure. Even the class A grade 1 recommendation says benefit is more than risk, but the risk is still there, right? So therefore, there is so much of variation in the patient's response to treatment, in the various treatments which can be given. And you cannot learn them till you do cases. So I really welcome all the participants, today's presenters. Today's presenters is Sadanand, who is a stroke specialist, senior man, and my own colleague, Dr. Praveen, again a senior neurologist, but not senior to me. He's a younger colleague, and but he is so busy that even though he works with me, I can't see him. Today I could not see him. He's so busy. So I'm seeing him in the webinar today. But he is very good. Stroke is his passion. And I also welcome the moderators. Meenakshi Sundaram, it's a joy to see you always smiling. I don't know what is the secret of your not being stressed. You're always happy. And it's really, I welcome Rahul. It's nice to see Rahul. And when I was talking about cases, Rahul knows. Rahul and me, we work in FINE program. And FINE program is based on cases. Even though we get the best of the international speakers, at the end of it, we want cases. That is the, that is the spirit of our FINE program, that because cases teach you so much. So Rahul, welcome to this program. And I hand over to Meenakshi and Rahul to carry on the program. And then after the cases, we'll give our comments and observations. Thank you so much. Over to Meenakshi.
So thank you very much, sir. Thank you for the inspirational words. I'm also raring to hear from two wonderful experts in stroke with so much experience in it. And of course, our most inspirational Rahul ji. He has always amazed us in his presentations, sir.
Thank you very much. Let me add one more thing. Sorry to interrupt you, because I want to say so much, but the time is limited. About Rahul only, since you talked. Rahul is an extremely academic man, even though being in private sector. We always think that when you are in private sector, you cannot do academics. But Rahul has such a big collection of cases. And Rahul has told me that one day he has kept only for academics. That is Saturday. Rahul, I don't know whether you still continue that. But couple of years back told me that Saturday is not for patients except for routine rounds. Otherwise, Saturday is devoted for academics and all these things. Being in private sector, I think hats off to you. Are you still continuing to do that, Rahul?
Yes. I'm trying to do that, sir. I continue to do that. Thank you.
Okay. Thank you, sir. Thank you.
Another feather in his cap and another inspiration to learn from. Thank you very much, sir. And I think we can go over to the cases after Dr. Rahul has come out.
Yeah, please. I think I am eager to see the cases. Stroke cases are always amazing, and the best possible decision sometimes can change over time to time. Retrospectively, you may sometimes think that I should have done this. But at the spur of the moment, probably you'll do best whichever is possible. And we'll hear some cases. Obviously, we'll try and done something. So I think we'll start with first case from Dr. Sadanand.
Sir, only one thing, sir. I've got a call for this case of stroke only. I will be off for a few minutes and then I will come back, sir.
Sure, sir.
Please excuse me, sir.
Sure,
Thank
sir.
you.
Okay.
Dr. Sadanand, sir.
Yes. Very good evening. I welcome all the faculty, and I just want to share my case and also want to get their opinion, how they think about this case and whether I should have done something differently or not. So it's always pleasure to have such a nice faculty, experienced faculty, so that we can learn more. So at the same time, I would like to thank MCure also to provide this platform so that we can share our cases and get opinion from all the faculties all over India. So without wasting much time, I will share my case. Let me know whether you can see my slides.
Yes, sir.
Okay. So this was a story of a 50 years female with a history of hypertension, non-diabetic, presented to us with the acute onset right hemiplegia and dysarthria and facial droop. Sorry, it was a left hemiplegia. this arthria and facial droop around 6 p.m. NIHS was around 12. She presented to ER around 8:30 p.m. So onset to arrival was around 2 hours 30 minutes. And this was the CT at onset. So I think you can see early ischemic changes here, perisylvian area M1, and like here also you can see M4, and dense hyperdense MCA sign also you can see here. So when we saw this CT, first thing what we did, we get back to the family members, and we wanted to be sure that whatever time they told is correct or not, because we can see almost early ischemic changes if very clearly visible. So we want to be very sure. At that same time, family members said that they are sure that this happened around 6 p.m. because before that she went to washroom and then came back. So we thought like probably they are telling it correctly. So early ischemic changes was at M2, M4 and perisylvian area. So we estimated aspects around 6 to 7, and there was hyperdense MCA sign. There was old right parahippocampal area. Also, there was a hypodensity. So probably an old infarct. However, when we inquired, they were not very sure. So we were not very sure that at that time that was symptomatic or not. So now the question was what to do. We can, a patient presented within therapeutic window, but we can already see almost established changes involving it's a moderate area of right MCA territory. So the question was whether we should go ahead with IV thrombolysis because the patient reached within therapeutic window. So it's 2 hours 30 minutes. And then because there was a large vessel occlusion, so just doing IV thrombolysis and then take the patient to cath ward and do the endovascular thrombectomy, because we know that with MCA, the chance of recanalization is not more than 30 to 35%. Or we should do with endovascular thrombectomy alone, because we can already see the early ischemic changes, and we know that we are at this point of time at equipoise, like whether we should do endovascular thrombectomy with IV thrombolysis or only endovascular thrombectomy, or we need further investigation despite knowing that patient's family are like sure that this happened around 6 p.m. So because our CT console is very nearby MRI, and because we could see the early ischemic changes which are almost established, so we thought to give a shot so that we can see whether in MRI whether we can see something which because we were a little bit scared about if we do IV thrombolysis, then whether there's a high chance of reperfusion bleed or not. So this time we also discussed about endovascular thrombectomy with family, but again, family undecided at that point of time. So the options left with us was a go ahead with IV thrombolysis because patient was still in therapeutic window. Now, if deciding for IV thrombolysis, any preference of thrombolytic agent, altiplase versus tenecteplase, or we should continue with conservative considering there is almost established changes in the right MCA area, or whether we can do further investigation to decide further course of action. As we said that our CT scan is very nearby MRI, so we thought that why don't we do a fast track MRI to get more idea about doing like intravenous thrombolysis. We opted with tenecteplase because family is still not decided about endovascular thrombectomy. So we thought we should, if like we see like significant diffusion flare mismatch or perfusion mismatch, diffusion perfusion mismatch, then we should go ahead with IV thrombolysis because family is still not decided about endovascular thrombectomy. And we opted for tenecteplase because now we know that EOSO guideline says that in a case of large vessel occlusion, tenecteplase is preferred over altiplase, and now we have Canadian guideline also, which also recommends almost in all type of stroke, like as a tenecteplase as an alternative to altiplase. So now we again thought like what investigation may be more helpful. So whether we should do CT angiography or not, which will give an idea about collaterals and all, or we should do a CT perfusion to see the like large area of perfusion, so that we can get an idea that there is a large salvageable penumbra, or we should do with MR perfusion, or is a combination of ever. So we finally decided with MRI brain, so that we can get involvement of parenchyma, diffusion flare mismatch, along with diffusion perfusion mismatch, along with TOF sequence. So this was the MRI at onset. So if you can see remember the CT, so almost similar, you can see here the perisylvian area, M2 and M4 area already involved, and there are a bit little early diffusion restriction in the basal ganglia region. And if you see the perfusion weighted images, you can see there is a large perfusion deficit. This was the perfusion area. So we can see here that there is already diffusion restricted, which matches actually with CT scan, but still there is a large perfusion area, so that we can salvage a penumbra. So you can see here the flare, there were no established flare changes yet. You can see there is no flare changes, and there was an old parahippocampal infarct, which already we saw in the CT scan. And this was the TOF sequence, which corroborated with the CT hyperdense MCA sign. You can see here M1 occlusion also here. So family finally declined for endovascular thrombectomy, considering because they have financial constraint. So we decided to go ahead with IV thrombolysis, because we can see a large perfusion deficit. We thrombolized with tenecteplase at around 9:20 p.m. So door to needle time was 50 minutes. So we got a little bit 10 minute, I will say 10-15 minute delayed because of this MRI and MRI perfusion. 1 hour post IV thrombolysis, NIHs came down to 6 from 12. This was the post around 24-hour post thrombolysis CT scan. So you can see here the established changes, which are almost matching with MRI. We already saw that in MRI also there was, when we did the MRI, there was already a early diffusion restriction in the basal ganglia region. And there was, this was the follow-up CTA done at the same time, and you can see the complete recanalization. And you can see here the very good collaterals also. So echo done was non-contributory. 48-hour Holter showed atrial fibrillation. We started him on around apixaban 5 mg twice daily on day 6 and discharge on day 7 with NIHs 4 and MRS 3. So now here we thought like what we can discuss here is a bad looking CT brain is a contraindication for IV thrombolysis, even in presence of large vessel occlusion, where like family yet not decided for endovascular thrombectomy or not agreed for endovascular thrombectomy. And particularly in such type of CT scan, if family would have agreed for this endovascular thrombectomy, so whether we should prefer EVT alone over like IV thrombolysis with EVT, considering there is a little bit increased risk of hemorrhagic conversion, particularly with aspect 7 or less. So we know that extensive and clear hypertenuation on baseline CT or extensive hyperdense GWI area on baseline MRI represent irreversibly damaged brain tissue, and therefore in such cases IVT may be of limited value. Although the degree of extension of this ischemic area that may render IVT futile or even harmful is not well known. And yes, for aspect 7 or less is associated with a little bit increased risk of ICH, but that not makes a contraindication for IV thrombolysis. So here in our case, the take-home message was like ischemic changes in CT scan should not be the sole reason to decide against IV thrombolysis. And sometimes higher investigation like CT angio, CT perfusion or MRI with MR perfusion may be of helpful in deciding further course of action in such cases. though there is no clear consensus about EVT with or without IV thrombolysis, because we are still at equipoise, it may be skipped in elderly patients who are in late phase of IV thrombolysis with high bleeding risk, like extensive white matter ischemia or cerebral microbleed. So here I rest the case. I want to discuss this case and want to get their opinion. Like first thing, my question would be to them, like what, like in such situation, seeing the CT scan, if the MRI would have not been available in such a center, what they would have done, whether they would have proceeded with IV thrombolysis alone, or they would have done something different, and whether this where we did the MRI with MRI perfusion, whether they like to do some other investigation like CT angio or CT perfusion, or they agreed that MRI with MR perfusion is like better in such situation.
Okay. Meenakshi, you would like to respond, or Rahul?
Sir, give me some time, sir. I have not been able to grasp that case I told you.
Okay.
Just now I came back, sir. Sorry, sir. That's a case I just sent for MRI right now, sir. I'll get back to you, sir. Sorry,
So
sir.
no problem. So Rahul, you would like to comment, or you want me to comment first?
No, you also comment, sir. You can comment first. But my question is, I have a simple question. Suppose if you had done a mismatch study, you did a multimodal imaging, and if it had shown that there was no mismatch, what would you have done? At 2 hours, patient has no mismatch. There's no mismatch. Then still, will you thrombolyze? Or because there's no mismatch, there's no point thrombolizing. Sometimes these multimodal things make the things more complicated than sometimes helping, yes, especially in a situation where patient is presented within so-called window period. We tend to use more of multimodal imaging in patients who are extended window, or maybe more of wake-ups, because sometimes in the window period it makes the life more difficult than making it happy or easy. So, sir, would you like to start commenting?
Yeah, right. So you see, the guidelines also say that within window period, and window period now is 4.5 hours. Yeah. Within window period, there is no need of doing any multimodality. This is guideline. This is guideline. There may be mismatch, there may not be mismatch, but the guideline is that don't try to waste your time in this. You thrombolyze them anyway, which means some of them may be having mismatch, some of them may not be having mismatch. But as per guidelines, we can thrombolyze, and your patient is within 4.5 hours. So that's as far as the extended imaging is concerned. After you cross 4.5, then you are basically crossing the deadline. Then you have to worry whether how will be the outcome, because then you can do all that. In fact, you can give IV thrombolysis up to 9 hours also. But then you have to show all these mismatch and all that.
Mismatch, yes.
Otherwise, up to 4.5 hours, I would not. I would have straight with thrombolysis. Now, coming to your CT scan versus MRI. You see, CT scan, two things CT scan shows. One is the depth of ischemia. Second is extent of ischemia. The extent of ischemia will be seen by whether 1/3 of MCA is involved, whether subtle changes are there, whether 2/3 is involved, whether entire. That will depend on where is the level of the block. Depth of the ischemia means it depends on the collaterals. That means how much black it is. So your patient has had a good depth of ischemia because within 2-3 hours it has become black. This happens only in 5-10% of patients. In 90% of patients, CT scan up to 6 hours.
We cannot see any change.
But so this used to be, this would cause us some stress before. But 2019 guidelines are very friendly to neurologists. 2019 guideline says that when you are within window period, no degree of ischemia extent and no depth of the ischemia extent is a contraindication.
Yes.
That means if your entire MCA is gone, still you are allowed to thrombolyze. Outcome may not be good. You are very right. Outcome will not be good. That you have to tell family. But you are allowed to thrombolyze. Similarly, if you are... previously they used to say if it is more than subtle hypodensity, don't thrombolyze. But now they say whether it is totally black thing, it is and it is involving whole of MCA, you can still thrombolyze. But a particular family may ask you that what will be the outcome. That time you have to tell them the outcome may not be good, but you can still do it. So considering that data and guidelines, this patient, because his hypodensity was there, but it was almost 1/3, not very much more than 1/3. And he was within window period, I would have thrombolized him. But at the same time, I would have definitely done CT angio or MR angio to make sure whether he needs mechanical also.
Yes.
So that is our usual protocol.
Yes. So we did in this case because it was available, and we wasted 10 minutes extra because we shifted from CT to MRI and we do fast track MRI. So because we actually saw the early ischemic change which was almost established. So we thought like before doing, at least we can get an idea.
That is okay.
Yes. And then, sir, again, one thing I want to know, like in such cases, like because we know now, like IV thrombolysis, EVT with IV thrombolysis or EVT without IV thrombolysis is still undecided, and there are not significant difference. So in such cases where you see almost significant early ischemic changes, and in like angio, whether it is MR angio or CT angio, you see the large vessel occlusion. So whether you are comfortable with both, or you prefer here in such cases EVT alone?
So in this patient, leukoariosis is a risk factor for bleed, but it's not such a big risk factor for bleed, like microhemorrhages. They are a bigger risk factor for. So in this patient, I would go by the conventional thing. I would go by giving first IV thrombolysis and then giving, because there are some advantages of giving IV thrombolysis also, because it softens the clot and all that thing. And if you see most of the data, that shows that the outcome was better without significant increase in the hemorrhage. So I think in this patient, I would go by the conventional thing of bridging, which means combining both. There are some situations where I would do mechanical thrombectomy alone. That would be in a patient where APTT is very high. I want to do that, or for instance, a cardioembolic stroke. Following a procedure, patient is having a hemiplegia and there is an MCA block, and they have already received heparin, and the APTT is like 44 or 45. In those patients, I would do mechanical thrombectomy alone, without doing. But now the good thing is that the guidelines have shown, the data is showing that there is some difference. Bridging is better, but the difference is not
significant. Yes,
it is not that significant. So either way you can do, either way, whichever way you are comfortable. So I think if you give the explanation that I was afraid of the leukoariosis, therefore I went with mechanical, you will be absolutely justified, and anybody will accept that.
Yes.
So that is one good thing, that today it's in our code. Either way we are comfortable, we can take the decision.
Yes.
That was this I have heard in an international meeting, experts saying that you take your own call, either way you are. Yeah.
Because it all depends like who are actually seeing, because if intervention radiology said they prefer like we can do just EVT, fast EVT, no worry, not to take risk with any.
But what happens, as Rahul said very correctly, we always take a judgment which looks correct to us at the nick of the moment. And it is the next day when you know I should have done that. Now what happens is that sometimes they are not able to pass through the clot. And then there is the first pass and second pass and third pass. And therefore they will, wish if I had given the IVTP.
IV thrombolysis and then, yes, agree.
Yeah, so, or sometimes if you have done like in your case, suppose if you have done mechanical in this patient as you wanted to do, you would have costed patient 10 times more.
Yes, 10 times more.
10 times more, and there might have been a complication also. Because one of the advantages of IV is that there is a 20 to 30% chance that you may get away with the mechanism. Right?
Correct. Yes. And we have seen recanalization with large, even ICA clot, we have seen recanalization with IV thrombolysis, particularly if the reach.
Yeah. So unless there is a compelling reason like this high APTT or patient crossing window period, I think it is better to stick to the combo. Meenakshi, how is your patient doing? Meenakshi, how is your patient?
No, sir. There's a bleed.
Okay. Thank God. Thank God for that.
So
you don't have to go.
So if I
if there is a early ischemic change, what is the original NIMS data said that these were some of the exclusion contraindications. Subsequent data said that whether they are there or not, overall the prognosis will be good if you treat. Again, in 2016 guidelines, when they wrote, they said that extensive early ischemic changes we should not do. So there has been a constant source of confusion with regard to this data on the early ischemic changes. How do they define it? They say that more than 1/3, then you should be careful. That word careful is very difficult for us to understand.
Difficult, yes.
Careful. After all, you are going to take it and just inject the drug, that is all. How can you be more careful than just injecting into your vein? I really don't understand. So in our policy, what we do is that, sir, within that 3-hour, 4.5 hours window, particularly I never accept for an MRI because it has been more a source of confusion than otherwise. I accept for MRI in our hospital in the 4.5 hours window only if I am not sure it is a stroke. That is the only reason why I do it. Or I find it that maybe vaguely it may be stroke, but it may not be that case. Otherwise, routinely 4.5 hours window, I think we just do CT, no bleed.
CT angio,
That's been our policy. Even CT angio, we do it only after the CT. Many times we just slice it and then do a CT angio. Even that time we just save. That's what we have been. Our policy is 4.5 hours or less, very simple for our residents. Do CT, no bleed, lice. Don't ask for the report of the scan also. This has been our policy. I do not know whether it is right or wrong, but it's what we have been practicing. Sir, is that correct, sir?
Yes.
Yeah.
I agree, Meenakshi. Our indication for MR in window period only 3 or 3.5, I would say. First is if patient has seizure at onset, sometimes you are worried. So that's where we do MR. Second, as you correctly said, in mimics, probably we would do MR. And in some patient, if the sugars are extremely high or extremely low, maybe sometimes we have never done this as of now. It is just written in our protocol. And third is, as sir said, in a large stroke, sometimes we may have to give a patient opinion that the prognosis is going to be bad, though even if you're giving IV. So that is a plus minus. So these are our 3.5 indications for doing MRI in first 4.5 hours. Otherwise, whichever patient comes, it is always CT with CT angio. That's it.
Yes.
Window, yes. And as far as EVT only you're concerned, we would do it in as someone who is or someone who has recently received an agent which can be troublesome. So that's where probably only EVT. And secondly, in patients, when you're doing it after very long period. Suppose sometimes we know that in basilar you do it after 12 hours or maybe in 18 hours. That's where probably EVT. So EVT only for those two indications. Otherwise, it is always IV followed by EVT. That's our usual protocol.
Also, with tenecteplase, one great advantage we had was earlier with alteplase, we had to just run the infusion. And I have found out that when we use the infusion pump, they will not take you into the MRI. Our infusion pump earlier was not compatible. Now we had to get one MR compatible one. Now with tenecteplase, that problem is solved. You just give one injection and just push them inside. The injection is often taken to the scan room to lice. Our MRI and CT are opposite each other. So we have a lot of advantage just pushing it and doing it. That's all.
Yes.
So Sadanand, if I ask you a question as if you have a case of LVO, a large vessel, will you always give tenecteplase or there are some patients where you're still using alteplase?
Sir, now we have switched completely to tenecteplase. Particularly if there is a large vessel, they always prefer tenecteplase because now it made our life easy. Even on phone, we see the scan and say the resident like you give the dose while we reach. So we don't waste time. So we always try to, sir, thrombolize within 30 minutes because that is the goal now. Yeah. So yes, in our case, it took a 10-minute extra. And I know that even if like MRI was not available, we would have thrombolized because we told family members that he might have a little bit increased chance of bleed because there is already, but still benefit outweighs the risk. But yes, sometimes because when you are doing and if you MRI is available, it will take 10 minutes. We do fast track MRI, DWI, flare and TOF sequence. So that's why we did. But I agree completely that we should not do a routine MRI. We not required at all. We just do CT, start thrombolysis, and sometimes we do after that we do either CT angio or MR angio. Because earlier what we used to do, we do CT and CT angio, but CT angio again takes 15 minutes extra, 10-15 minutes extra. So that's why we don't waste much time. Just do CT, no contraindication, thrombolize, and then do CT angio. If large vessel occlusion, ready for like cath lab if family agrees.
So one more thing, sir. Our own practical experience is that the duration of time spent for counseling for IV thrombolysis is inversely proportional to the acceptance rate. Look at the cardiologists, they don't even see the patient. They just see the ECG and give injection, they don't even counsel. I have not seen a cardiologist sitting and counseling a person for IV thrombolysis talking about hemorrhage anywhere. I think we should have a thing to learn from them. True that we should explain. But I feel that many of us neurologists we keep on explaining to the patient about risk of bleed, and ultimately lose the time. So I found out that whenever I was taken less time, I say that there is a stroke and we have to open the vessel, we have to give. Rest of the things we'll see later. And there is a 6% chance of bleed. The acceptance rate is phenomenal. Than sitting and spending too much time with them. I don't know what is your experience, or we take Paul sir's and Rahul sir's experience. Lesser the time we spend, more the accident, because we are ultimately doing good. Why should we really feel sorry about it? We just quickly we do it and take the decision. Is that
one of our emergency resident, he did a thesis of breaking out door to needle time, and he was looking at which was the step where maximum time was spent in the door to needle time. And we found that the maximum time, this was, of course, I'm talking about more than 5 years back. We found that the maximum time was spent was for consent. The doing CT scan reading, neurologist coming in time, everything was possible. Getting the injection was possible. The issue was, talking about the consent. So we found that actually the bottleneck in our testing center was this consent part. So now we are trying to start, we are doing it, as you correctly said, simplified version. And fortunately, now the awareness also is improved phenomenally amongst, at least in urban area. People are forthcoming, asking for the so-called injection. So, the awareness is improved definitely. So that time is becoming lesser and lesser. And now that because the drug is being a standard of care, actually we shouldn't be taking consent. If you ask them to sign on something, that means you're doing something which probably usually you don't do. So you don't take consent when you're giving aspirin. It is a standard of care now. Doing IV thrombolysis in a window period is actually the standard of care. You take consent probably for something which is doing out of standard of care. So I don't know whether we should continue taking this consent, because it is a consent. If you ask the relative to sign, that really creates sometimes havoc. They would like to call some doctor or some family member. Every one of us has faced this. I don't know what's your opinion.
Yeah, agreed, sir.
Continue taking consent, especially when it is a standard of care now.
If we don't take consent, if there is a bleed, we are in trouble, sir. So maybe you are, the big this one, sir. We are not. So they will beat us, sir. Better take consent, but tell them on the face. I tell them 6% chance of bleed and tell them, sir. And many times I ask them to take a video recording of me telling them that. So that increases their acceptance rate. I've always seen. You say, take a video, I'm going to talk to you. There is a stroke, I'm going to lice, take a video, 6% chance of bleed. Even for that replace, they use the same 6%. You go and do it. They are always accept. Because they think that something has been recorded and this doctor cannot be at fault.
Okay.
But consent, without consent, difficult. I don't know, sir. Paul, sir, is consent required, sir?
You see, this consent thing we have debated for many years, and we used to get so stressed by it. But I think now we have perfected this art of consenting. A simple injection can cause death of a patient. Simple injection by anaphylaxis can cause death of a patient. Similarly, when we do any operation, any routine operation in a hospital, you have to take a consent from the patient. So we should not spend that much time. What we do now is that we don't give long lecture on the pathophysiology of stroke, which you used to do. We just tell him that, look, this thing has a stroke, and the only treatment available at this time is this thing. And please sign it here. There's a chance of bleed also. Invariably, they accept. It is a routine thing. There's a routine sentence which you have to talk like a parrot. Not too much of pathophysiology. Yes. Look, I'm going out. This is the best which can be given at this time. And it has to be now only. There is a small chance of bleed. Even 6%. Why are you telling percentage? He's not a statistician. Tell him there's a small chance of bleed. But then benefit is much more than 99% success. They don't go into, they are themselves in stress at that time. They will accept anything that is. I also agree with you, Meenakshi. It's better to take consent, even though Rahul says no.
No, I'm still taking it, sir. I'm debating whether we should take it or not.
No, I think it is better, because you see, out of your 100 patients, one patient is enough to cause misery to you. There may be some relative in US or somebody, and sometimes they may question your indications of giving it, whether it was a minor stroke, whether it's better to take 2 lines and get it signed and get rid of the tension.
Sir, I learned from one. There is an anecdote, sir. There was a college professor from nearby. His daughter is from US. They brought to us, and that same James Bond time, 5 minutes to thrombolize. So that time I remember, sir, I told them that this was my consent. I said, I'm putting a gun on your head and I'm telling you for your fun. You came with Wernicke's aphasia-like presentation. I told pure Wernicke's aphasia, the prognosis may not be really good in terms of aphasia, but this is the best. She said, no, you have to sit and give an explanation. That's what they do in US. I said, I am not giving any explanation. Just take the explanation, record it now. I'm giving you 1 minute to sign that I'm going to give an injection. This is stroke, and I'm going to give an injection straight away. You accept 6% risk. You don't, I'm leaving. She signed. I gave injection. Then we took for CD and then we sat and talked. It has worked.
Meenakshi, you should not have been that rude to her. Same thing you could have said nicely also.
Sorry, sir, sorry.
You could have said same thing. But I have had to, as doctors, as long as we are practicing, we will get these problems every day. Tomorrow also you will get a US relative and he will be in the same. So we have to get used to it. I'll tell you two very mini anecdotes. One of it was Andhra Pradesh High Court judge's mother came with an IHS of 2, right? And naturally now 2. So we were worried, should we thrombolize or not? Because mother is a judge. Tomorrow she may sue us and she will sue and she is judge also. So should we give or not? If she progresses, again a problem. And if we have given it, then we have thrombolized a minor stroke. But we know we thrombolize minor strokes also. So I told her very straightforward, very respectfully, madam, this is this thing. It should be thrombolized. Some people don't thrombolize, but we would like to thrombolize because it is. But you will have to sign it. She quietly signed. And the patient became totally all right also. And better than that anecdote is, this thrombolysis, it took us 10 years to get DCGI approval in our country. But TPA came in 2000 only. It was at the time marketed by German Remedies. And German Remedies were not even interested in promoting it. They did nothing. I mean, they're unlike Emcure, which is moving earth and sky to get it 4.5 hours and all. German Remedies didn't bother about it. We had to go to Bombay and get it and all. And it was already given in DCGI for approval. It took 5 years for DCGI to approve. Now, during somewhere in 2001 or 2002, some DCGI senior person, I think he was vice president or something, his mother got a stroke and she was brought to our hospital and she was in window period. And I told her that there is one drug which can be given, but it has not been approved by you as yet. So should I give it or not? But I did not. I mean, I was not mean. I told him very sympathetically, sir, but it is working. It is working all over the world. But there are some bureaucratic problems here. It will take some time. He said, doctor, go ahead and give it. I said, then please sign it. He signed it. He signed for an unapproved drug by his department. And but it is always better to take a signature. Okay.
Thank you, sir. Apologies for that. Thank you, sir.
But suppose if there is no attendant, if that also happens. Sometimes people are got from the factory. You see, I think one of the things which I have learned over the course of time, we should always think for the best interest of the patient. We should not go so much for, we have to think of our safety also and patient's outcome also. I mean, we should practice medicine really in a sincere way, not absolutely defensive and not offensive at all. So it can happen sometimes, and it has happened with me. That's why I'm telling you. A patient is brought from a factory with a stroke, and there are 10 workers, and nobody is taking responsibility of giving TPA. At that time, I have thrombolized. I have written no family member available. The office workers not given consent, but it's in the best interest of patient to give thrombolysis. I've given thrombolysis. I can justify it in any court of law. Nobody signed, but I still gave it. I signed for him. So that thing can happen sometimes, but you have to know your science and why you are doing. So there are situations where we may not need consent, where we will not. Thank you, sir. I think we have spent a lot of time in this discussion. We can go to next. Praveen, are you ready?
Yes, sir. I'm ready, sir.
Is your new laptop working? Is your new laptop working?
I think so, sir. I think the screen sharing is okay, sir.
Okay. Yeah, it's perfect. It's beautiful. Slideshow. Please do slideshow.
Yeah, sir. Yeah, hopefully my case won't be such long one, but there were some points I wanted to make. Therefore, I chose this case for presentation. Thanks to Kaul sir, Rahul sir, and Meenakshi sir for giving this opportunity, and especially Emcure for holding such a good symposia so that we can share our knowledge. And this is the tagline. This is as Kaul sir had taught us. Just do it. Whenever you have doubt whether you want to do or not, just go for thrombolysis. This is what we have done, and I will share it. Yeah, this was a dreaded call which I received on Saturday evening one day that are you available in the hospital? This was the rheumatologist resident who called me at about 6:30 in the evening. Are you available? And my heart sank, because whenever there is such a call on Saturday evening, that entails a long night. And I told yes. And this was a patient. There was a big bagged history. I will get back later. But he told, I am just writing the discharge for this patient who was admitted, obviously. Suddenly he has double vision and he's swaying to the right. And also he noticed that he was complaining. He could see that he was having a left droop. This is what the rheumatology resident was telling me on phone. And I realized he automatically told, this is most probably a stroke, sir. I am going for scan. I am doing the scan. And I had a little knowledge about the patient. Before the scan, I would like to tell about this patient. He's a young gentleman, 30 years old, who had come with severe arthralgias. I myself had seen him twice, and he had been seen by physician, orthopedicians, rheumatologists. All initial reports were negative. In fact, he had such bad pains that he had stopped his job and went into depression, and he also had suicidal thoughts. None of the painkillers were helping him. Along with that, recently he started also having low-grade fever. And on the backdrop of it, he was extensively evaluated. PET scan showed he had arthritis of the large joints, especially the axial, involving the sacroiliac joint. Therefore, sacroiliitis was considered, and he was admitted for immunomodulation. That was the purpose. And fortunately or unfortunately, in the PET scan, they found out that there was a ileal thickening. And when they did the biopsy, they found out he was having amoebic trophocytes. And the biopsy was done about 10 days prior to admission. And on the background of it, when they went back to the history, they found that his sister had SLE. Therefore, he was evaluated for SLE. The markers were negative. But APLA, all three lupus anticoagulants, IgG, IgM, or the microglobulins, all were positive. Therefore, this is a patient with APLA syndrome, but so much arthritis, axial arthritis. And on top of it, just at the time of discharge, he had received such immunomodulators which were not approved, and because they didn't have any other option, the pains were not going. They had to use many of them, and on verge of discharge, he had this. Therefore, on examination, this is what he told me. In fact, there was a left eye was ptotic, there was adduction and elevation were restricted, and there was a nystagmus on the right eye. And he had a severe truncal ataxia. He couldn't even sit. Therefore, on phone only, we could calculate the NIHS was 4 because of the severe gaze involvement and the limb ataxia. But in the back of mind, I was thinking what happened, whether the antibodies, whether it's straightforward, it was a stroke, but whether something else has occurred, APLA causing a venous thrombosis, or whether it was some demyelination which had occurred the brainstem. Therefore, here I deviated. He called within 15-20 minutes of the stroke, but we do the CT, but here I deviated and I went for the MR. Before this, just I wanted to show the localization and just a recapitulation of our thought. And as we know, brainstem, they have beautiful mnemonics and beautiful names for the various syndromes. And our patient possibly had the Claude syndrome because he had the severe ataxia along with the oculomotor palsy. Another which is similar to that is the Benedict's, but it will be having a hemiparesis, whereas Weber's won't be having so much of ataxia. It will just be oculomotor palsy and opposite hemiparesis. One more important is the Nautnajan syndrome, but here it's not due to the stroke. Usually it is due to tumors which involve the tectum. Therefore, here we have a lesion possibly which is involving the oculomotor nerve and the red nucleus involving the some of the superior cerebellar peduncles. This is the site of, he had clinically the INO. As we all know, it is the MLF which is involved, which has caused this problem. And clinically, these were the three things involved. The third nerve, along with the fibers decussating the superior cerebral peduncle, along with the red nucleus also. Therefore, when we did this, hopefully it's visible. Just there was a speck of a diffusion restriction. Hope you can all see it, sir. There was speck of this just nearby the aqueduct in the tegmentum, which with some amount of ADC mismatch. This was the acute thing. Otherwise, there was nothing in that. But he also had a significant involvement of in the T2. We could find out that there were many silent ischemic changes also. But the thing which had caused the problem was the involvement as we had thought it. In fact, the MRI technician was circumspect, but no. Clinically, this is it. He has it. He has acute stroke. We have to thrombolize. But we did because we were thinking of a APLA, we looked for vasculitis. The large vessels were pristine. There was no evidence of any beading or any evidence of any constriction noted. Therefore, this was a Claude syndrome. It involved the left dorsal. I wrote it wrong. It's TOAST 5 because there are two things. One, there is APLA, and also the type of infarct is that's a Lachner infarct. Therefore, it's a TOAST 5, and the NIHS was 4. And as the patients, we knew the patient and the attendants. I just came out and told the same, that we have to thrombolize the patient, and they gave the consent, and we are normally at our institute, we are giving still at 0.2 milligram per kg body weight, just keeping compliance with our national compliance, national guidelines. He didn't have a dramatic recovery as soon as we sometimes see, but within 3-4 days, he was able to walk with some amount of ataxia, and at discharge, we initiated him on azithromycin because this was a primary or a secondary APLA syndrome. Yeah, this is what yesterday I saw. Sorry, I couldn't get the video. Therefore, this is just a screen grab from the video. We can still appreciate the left ptosis which he had, and I saw the eye movements. The eye movements had settled down, and he had come walking alone without any support. Therefore, the point here why he wanted to that, because about 15 days prior to this, he underwent a colonic biopsy. Therefore, that was the major point thought. Should we or shouldn't we? Mucosal biopsy from a site which is not compressible. Is it a contraindication? Should we have done that or shouldn't we have done? But looking at the amount of disability he had, and almost about 20 days had passed, and it's a relative contraindication at best. Various studies, the NINS trial had suggested 14 days, whereas the ECAS says about 3 months. And that is the point where here I wanted to say that still looking at the benefit what we have given, I think so we took the right decision, and we went for the thrombolysis. And other major point, as we all know, the posterior circulation nor a Lachner infarct is a contraindication. But the major important point I want to make is that in our hospital also, many of the in-hospital strokes get unnoticed, either by nurses not just telling, or it's post-surgery, or that the awareness about the possible thrombectomy is not there. Therefore, as I was searching for the literature, in best of the settings, almost more than 20% of the in-hospital strokes are not thrombolized. Possible that is one area I was thinking of spreading the awareness. That was one more point I wanted to add, because here, because of the astuteness of the resident, we could take the call and we could thrombolize within about 40 minutes of the onset of the stroke. This is, I would end, sir.
Good. Thank you, Praveen. Great case. Meenakshi, your comments?
Sir, really wonderful case, sir. There are many points of interest. The first thing is about the colonic biopsy and this one. I think that we should have thrombolized, and he has done the correct thing in my opinion, sir. I would have also thrombolized, because if at all it's a biopsy, I'm not sure whether it's a major surgery, then it's fine. I do not believe that biopsy per se will really produce much bleed, and we can always go in and try to intervene if there is a continuing hemorrhage. I would have thrombolized, sir. The lacunar stroke also, all of us we thrombolize, whether we diagnose or not, we just say thrombolize. The point of interest is the Appler syndrome and this one. There are two things here. One is that in Appler syndrome and stroke, it's always, it's one of the situations where we should always understand that anticoagulation is to be administered, and at the baseline, the raised APTT or raised PT, when it is there, it may confuse us, because that is part of the syndrome and may not be really reflective of a coagulated state, anticoagulated state. Irrespective of that, we have to thrombolize at that time. In a known case of Appler syndrome, that is where the confusion will come. The second thing, one point of interest I would like to take the audience view is that earlier we used to say that for Appler syndrome, do not use direct oral anticoagulant, the novel oral anticoagulant. Has it changed now whether we go for NOAs? These are my points here in this case.
If you ask me my take, probably the patient was seen by a rheumatology resident, right? Not by
Yes, sir.
resident. Had it been a surgical resident, he would have 100% missed the stroke. So because the patient was seen by a medical resident, it was picked up.
Yes, sir.
Many times the in-hospital strokes are missed because they are the strokes which occur in surgical wards, where they miss the stroke for 24 hours. So we have to improve awareness amongst our surgical residents also, as well as the surgical nurses and the ward boys. In-hospital stroke has to be thrombolized. We should make a maximum attempt, because this is an ideal situation. You can actually thrombolize in 10 minutes, 15 minutes after the onset of stroke. So we have to sensitize our residents for this. Yesterday, I saw a couple of days back, I saw a stroke. Patient undergone some oral surgery, and then it developed a big MCA, which was picked up after 40 days in the ward. So, this shouldn't happen. Because your patient was seen by a rheumatology resident, he or she picked it up. Had it been a surgical resident, GI resident, he would have missed it definitely. So that's number one. Number two, looking at the site, the infarct is in the midbrain pontine area, and there are multiple infarcts in the same area. So, this is an area where you get infarcts, especially in Behçet disease. The mesencephalic diencephalic junction is an area where you get infarcts in Behçet. So, I don't know. Unfortunately, we have no end markers for Behçet. So, it's probably a clinical diagnosis. I don't know whether it was really Behçet. It's a rare disease in our part of country, but we had seen a couple of patients who were infarcts in this area, and we proved that these patients had Behçet. So, that's one thing. And of course, as you said, this is a myth that, you thrombolize all, even lacunars also we thrombolize, even minor strokes we must thrombolize. Good case. Thank you.
Yeah, I think Praveen, as far as the major surgeries are also concerned, after 2 weeks, we can thrombolize them after 2 weeks. And this patient had exceeded 2 weeks. Because this can happen. Suppose a patient has undergone an abdominal surgery. Suppose a patient has undergone a cardiac bypass surgery. It happens. So up to 2 weeks, they are saying you should not do it. After 2 weeks, you can do it. By 3 weeks, definitely. Yours was almost 3 weeks. That is one. And of course, that lacunar stroke and all is not a contraindication. And the other thing is that in thrombolysis, when we thrombolize a patient, usually there is the etiology at the time of thrombolysis is not given much, as long as a stroke occurs. The only thing in which there is some discussion is that if it is a stroke because of some infection.
Yeah.
And usually in infective strokes, it's very difficult to, take TBM, for instance. If a patient of TBM gets a vasculitis and a stroke, will you thrombolize him or not? I think there is no data on that. In the NINDS study, there were no patients but I know I have seen some case reports where people have thrombolized that. not a contraindication also, but that is one thing. Of course, one contraindication, infection is a gray area, Praveen, really, because if you take infective endocarditis and the patient gets a stroke, you cannot. But short of infection, I think we don't, even if it is because of vasculitis or anything, you can go ahead and talk.
Yeah.
Then
one more infection, sir, is mucor. Mucor strokes was a common phenomenon during this COVID period.
Yeah. So what would you do then?
And there is a data that, those people who are lies, there was a devastating deficit. So
yes. So that's right. So I think infection is one red flag.
Yes.
And I remember there was one, these people have always asked that if there is a TB vasculitis, would you even give aspirin in these patients? So nobody has done a study. How do we know about it? I mean, Rahul is an expert on infection, Rahul, I just forgot. So you would be... So what is your take on thrombolysis in infection, other infections also?
Probably no.
Yeah.
Because as you correctly said, TBM is sometimes difficult to pick up that he or she has stroke. But yes, there is some data of use of 325 milligram aspirin as a preventive. Like steroids that we use. There's some data that the aspirin actually can be. So nowadays I use aspirin in a lot of patients. We give 325 milligram aspirin in many of my TBM patients, even those who do not have vasculitis.
So yesterday I got a phone call in Hyderabad only from one of the doctors that he had done a renal biopsy in a patient, and next day after yesterday renal biopsy was done, today patient got a stroke, and he told me, should he thrombolyze or not? I told him no, because you have put a long needle, true cut needle into kidney, and it is non-compressible. Although I was wondering, is kidney compressible or non-compressible? No.
No, it's not compressible. I don't think kidney we would.
So these questions come sometimes, but I think your case was great. But what I liked best, Praveen, was the localization. That was beautiful.
Yeah. Sir, in this, the resident was so proactive. He's Harsha, sir. You will be seeing him, sir. He's a very nice clinician, sir. 2 points, sir. One thing, sir, he was extensively investigated. When I went to the rheumatology department and told that I will be discussing this case in a forum, they all became the HOD. He is a very learned man. He told that, yes, still it's at our wit's end because of APLA having so much of sacroiliitis. And I remember, I am not so sure, but Behçet's was also ruled out, I think so, Rahul, sir. Okay. And
no, but how can you rule out Behçet's? There is no test for Behçet's.
They did the HLA marker, sir, HLA 51, sir.
HLA 51.
Yes, sir. They had done it, sir. Therefore, that was
only because of the site of infarct,
Yes, I agree.
Diencephalocapillary, that's the site of Behçet's infarct, and there were lots of infarct that you showed in the FLAIR and T2 also. That's why I thought.
Sir, at one more point, sir, there was a Dr. Guy Thwaite who has done remarkable work on TBM. In fact, in one of the talks, he suggested aspirin 700 mg, sir, for as a anti-inflammatory, along with dexamethasone. For preventing strokes and TB meningitis, sir.
So this was for as a preventive, or when a stroke happened, they like because of vasculitis. So this was preventive.
Not just for stroke prevention, but also for not only for stroke, but also for other purposes where we use steroids to prevent the neuronal damage or the inflammatory cascade. He thinks that high dose of aspirin is good enough, and then it's a simple drug rather than going to drug like thalidomide or infliximab. I think it is worthwhile that we can use aspirin. So nowadays, I know that he had said 700. So I started using 325 at least in our patients. So routinely I use dexamethasone with 325 milligram aspirin in our TB meningitis patient for last 1 year.
For how long you use?
Again, a difficult question to answer. Probably I would use it till the time we use steroids. Probably.
Okay.
Sir, infection and stroke, when you said COVID should be an exception. We also published that.
Yes.
Yeah.
Infection where we thrombolyze freely is COVID.
Yeah.
So now we have COVID out of our mind because probably we are settling. Hopefully we didn't get it again.
So we had a series of like COVID patients, 10 patients we thrombolized and COVID, which were simultaneously positive with COVID. So in few patients we thrombolized and then detected to have COVID, and in few patients when we did CT at the same time we did the CT chest also, there was suggestion. So we did actually 2 endovascular thrombectomy also in a COVID patients. So at that time was difficult when there was actually Delta variant, because there was restricted examination, and like sometimes our residents even failed, emergency residents failed to pick up, and there was late also. So that time was difficult, but we still like a series of 10 cases where we thrombolized in a COVID positive patients.
Did this patient have any lipido reticularis or any of those markers, Dr. Praveen, sir?
No, pathology was also negative for him.
And the challenge is...
As I recall, sir, the problem was pains, severe pains, severe enthesitis.
The patient is going to require lifelong anticoagulation.
Yes, sir. Yes, sir. Yeah. In fact, he was on antiplatelets before, because he had stopped it somehow, but I was not sure what had happened. But obviously, he will need azithromycin for lifelong.
And also the prophylactic role of antiplatelets in primary antiphospholipid just we detect has not yet been established. Except for pregnancy, probably no other data.
Sir.
Pregnancy, yes. Otherwise, no, we do not left to the physicians to decide. And anticoagulation, there is only one thing, whether we can use novel anticoagulant. There is now recent data, I think it says we could use it, but I haven't used. All of us have stuck on to azithromycin. What he says is to take the expert opinion also about the role of novel anticoagulants in antiphospholipid antibodies. Is it good enough?
Our hematologists use it a lot nowadays.
Sir?
Our hematologists use a lot of newer drugs, newer anticoagulation in antiphospholipid syndromes.
No, but we have to be careful. There has been some data where particularly rivaroxaban has caused a lot of bleeding in these patients. Therefore, as a caution, it is clearly mentioned that we should not use novel anticoagulants. Although the data is on rivaroxaban, but they have cautioned it. It is only an oral anticoagulants like vitamin K, warfarin. But in some cases, when a patient gets an event in spite of warfarin, then either you have to up the INR or you can add aspirin at that. That's also allowed. Either adding aspirin with a medium INR or upping the INR. Either one, depending upon how aggressive the neurologist wants to.
3.5 target.
Yes. But that's okay. I think we have to restrict our discussion to thrombolysis. So, any other point on thrombolysis?
Sir, the dosage, sir, 0.2 or 0.25, should we now use? That always, I keep on asking you, sir. What should we do, sir?
We can ask others.
So dose of which one, sir?
Tenecteplase, sir, 0.2 or 0.25. Yeah, dosage, sir. Dosage.
0.25, sir.
Okay.
They shifted completely to 0.25.
I think
so
we can use.
also came in Lancet was 0.25. They shifted completely.
No. Why Praveen is saying is that the dose which was approved in India was 0.2, because at that time the trial was done with 0.2. But I think I agree with you. We can simply use 0.25. There should be no problem.
Sir, all the weight we are thinking is only a guesswork, sir, because we are not actually measuring. So we can always justify whatever dose we give. That is equal to 0.25.
That's true.
Agree.
That's true. So any other point? Rahul, you want to make any point?
No, sir. It was a wonderful discussion. I think it's always good to discuss cases. You take at least one or two carry-home message or take-home message from each case. So both the cases were brilliant. Both the presenters were brilliant, and we had a good discussion.
Thank you, sir.
Good faculty around. So thank you.
Thank you. Thank you. So Sanket, can you take it over from here?
Thank you, sir. I think it's been long that I have not come to this platform, sir. There's a different medical advisor who takes care of this now. It's Dr. Ajinkya Nanavre. He's not well. That's why I came in. And, having a discussion on a case for more than half an hour has been an utopia for me per se. The reason I'm giving you is because I attend so many webinars and we facilitate so many discussions. But one discussion, one case, and more than 30 minutes of discussion, and unique set of ideas popping in, giving all the listeners a different approach to the same case for the best outcomes of the patient. I think that is what this platform, you sir, Dr. Kaul sir, Dr. Kulkarni sir, Dr. Sundaram sir, and our expert speakers today, Dr. Aditya sir, as well as Dr. Sadanand sir. I mean, that was a fabulous discussion. We extended by 15 minutes, yes, but I think no one would have had that complaint ever, because what they have reaped from this meeting would be completely a new, thoughts and thought process towards managing their case. So I thank everyone, sir. I thank individually everyone for sparing their time today, the expert speakers who have presented beautiful cases, which initiated beautiful discussion. Dr. Kulkarni sir, for your expert, pearls of wisdom that you have shared today. Dr. Sundaram sir, for your expert comments, and Dr. Kaul sir, for your leadership in getting and being present for every meeting and chairing the meeting. Sir, thank you, each and every one of you, for your time today. Thank you, and I wish you a great evening ahead. Thank you.
Thank you. Thank you, dear friends. Thank you.
Thank you, everyone. Thank you. Take care. Bye-bye.